Okay, assalamu alaikum. So now we reach the final session. It's the last, but by any means, it's not the least important session. We have four speakers. They are very distinguished speakers. We'll start with the first one.
So I have the pleasure to introduce first speaker, Dr. Badal Alahmari. Dr. Badal Alahmari is a consultant at the Division of Adult Stem Cell Transplant and Cellular Therapy, Department of Oncology at King Abdulaziz Medical City, Riyadh, Ministry of National Guard Health Affairs. He is also the chairman of the Blood and Cancer Research at the King Abdullah International Medical Research Center in Riyadh, Saudi Arabia. And Dr. Badr is going to talk about advancing chronic GVHD care from evidence to praxis. Dr. Badr, please go ahead.
Right, Assalamu alaikum wa rahmatullah. Good afternoon, everyone. It's my pleasure to present about chronic GVHD today. I'd like to thank the organizing committee and thanks the Sanofi for the sponsorship. So as we know that chronic GVHD is one of the complications that happen post allogenic stem cell transplant. Is a syndrome that simulates, let's say, autoimmune diseases, occurring up to 70% of patients at different severity. The most common involved organ is skin, followed by mouth, liver, eyes, and others. And by definition, classic chronic GVHD can happen anytime. It depends heavily on the form of presentation and the kind of syndromic feature of the presenting symptoms and signs. We can diagnose chronic GVHD based on that, regardless of the timeline post-transplant. Risk factors, there are universal risk factors that is known for a long time to be associated with an increased risk of chronic GVHD, including mismatched donor transplant, mobilized peripheral blood stem cells, the type of conditioning regime, myeloablative versus rare reduced intensity, and the donor and recipient age. Chronic GVHD overall can be mitigated with the use of advanced and recent improvement in the GVHD prophylaxis, the form of in vivo T cell depletion. For example, data from 2 randomized studies showed that incorporation of ATG has resulted in significant improvement in the development of chronic GVHD, as well as nowadays the use of BTCY has been shown in at least 3 randomized studies outside the haploidentical setting showed there was an improvement in the graft versus host disease-free, leukemia-free survival rate for this by doing this intervention. Nonetheless, the non-relapse mortality post stem cell transplant is significant, and one of the leading causes for non-relapse mortality is actually GVHD. Chronic GVHD is a significant cause for non-relapse mortality, and it can account to up to 37% of all patient population underwent allogenic stem cell transplant, indicating an unmet need to control this, to prevent first, and second, to treat this kind of complication. Biologically, chronic GVHD undergo multiple stages. The initial phase is an inflammatory phase, where it really exerted through the innate immune response with the role of some cytokines that can play into this, followed by a cellular stage where the recruitment of the immune cells, different kind of immune cells, has been shown to implement in the pathobiology of chronic GVHD. The latest stage is the collagen deposition and fibrosis. So there are an impairment in the tissue repair associated with the chronic GVHD, driven primarily through the macrophages, the fibroblast, and some molecules such as TGF-beta. Mainstay of manifestation, so it can involve any organ, to be honest. I mean, chronic GVHD can be involved any organ, commonly skin, eye, mouth, and lung, one of the devastated complication of chronic GVHD or manifestation of chronic GVHD. So any form of fibrosis we can see in these organs. And the aim of treatment usually is to induce some remissions, although it's rare to induce, not really common to induce complete remission, especially for those who are relapsed, who are refractory to the steroid. But the main aim of treatment is to minimize or reduce the symptom burden, improving quality of life, and prevent further immunosuppressive, and with that you prevent the increased risk of infection. Well, we know that chronic use of immunosuppressive has been associated with increased risk of infection, metabolic syndromes, and chronic fatigue, reduced quality of life, and even increased risk of certain type of cancer. It has chronic GVHD has an impact, huge economic impact. There are some data from, at least from US, showing that 71% of chronic GVHD patients, they lost their income, and more than 50% they have to reduce their working hours, and around 1/3 of patients, they lost their job, indicating an unmet need. In terms of systemic treatment, if it is indicated, when it's indicated, usually we treat some patient with moderate and severe chronic GVHD. We usually do systematic treatment. And the standard treatment here is use of glucocorticoid, usually 0.5 to 1 milligram per kg per day. And this can induce remission up to 50% of patients. However, usually the course is prolonged and associated with increased exposure to glucocorticoid, and you know that with the exposure to corticoid, there is an increased risk of complication as well from the treatment. Assessment of response is very important after the use of with the initiation of steroid. So the definition of steroid refractory based on three things: whether they are refractory from the beginning for the steroid, or they are steroid dependent. So whenever you taper down the steroid to the minimum doses, then they will flare up again. And the third type of is the steroid intolerance. I mean, they are on steroid, they are responding nicely, but they developed a lot of complications. They could not tolerate the steroid. And this is based on the NIH criteria for response assessment. So what happened to those patients who met one of these criteria? Usually we start the second line. The standard second line now is the use of Jakafi or ruxolitinib, which has been shown in the REACH3 trial, randomized study showing the superiority over the best available therapy, and it's our standard of care. We know that the prolonged use of steroid, as I mentioned again, associated with a lot of complication and reduced quality of life. And once patients pass the stage of the first line of therapy, usually the duration of treatment is around median duration is around seven months, and around 70% of patients somehow they will require a second line therapy, and that's indicating unmet need. And subsequently, this second line therapy usually has short-lived, and subsequently the patient will require a third line of therapy, which is required for up to 50% of patients. Options for third-line therapy is palbociclib. Palbociclib is a ROCK2 inhibitor, has been approved since 2021 for patients age above 12 and above with chronic GVHD who fail at least 2 or more lines of therapy. So we know that ROCK2 is a molecule that works in the downstream signaling of some cytokines and growth factors, and play a major role in phosphorylation of STAT3 that is associated with increased or expansion, development and expansion of the Th17. Th17 cells are well known and well documented to be mediator of GVHD. And also ROCK2 block the STAT5 phosphorylation, which is essential for the expansion and survival of regulatory T cells. Again, it's a cellular component that is well known to be preventive measure for development of GVHD. So it has a pivotal role in the pathobiology and progression of the chronic GVHD. So what happened with the use of palbociclib, which is the first-in-class selective inhibitor of ROCK2, that by blocking ROCK2, you will actually allow the phosphorylation of STAT5 that can lead to expansion of the T-regulatory T cells, and you'll block the STAT3. With that, you block the secretion of different cytokines, actually, not only IL-16, but also interferon gamma and IL-2 as well, and lead to control of GVHD. So based on a pivotal trial, the ROCKSTAR study, which is a phase 2 randomized study where the enrolled patient of 12 years and above who had persistent chronic GVHD with 2 to 5 prior lines of therapy, they randomized patient into 2 different doses, 200 milligram once daily, 200 milligram BID, with the primary endpoint was overall response rate. In terms of patient characteristics, overall median age was 54, and median time from chronic GVHD diagnosis to enrollment into the study was 28 months, and median dose of prednisone was 0.919 milligram per kg. Severe chronic GVHD account for almost 70% of patients. 4 and more organ involvement account for almost 50% of patients. Looking into more than 48% of patients receive at least more than 3 prior lines of therapy, indicating heavily pretreated population. And the ibrutinib were used in 1/3 of patients, and another 1/3 they have an exposure to ruxolitinib, which was the standard of care at that time. So we have data for 1 year and the 3-year follow-up as well, which was showing equivalent overall response rate, which was the primary endpoint, which was met, indicating that there is a sustained responses for the use of palbociclib, and both doses were showing the same overall response rate, something around 74 to 76%. Majority of these responses are partial remission, which is something acceptable in this advanced stage of chronic GVHD. And again, the main focus is really to minimize the symptoms, decrease the symptoms of burden, and also the improve quality of life. Responses were actually achieved across the different organ involvement, with the upper and lower gastrointestinal system showing the highest response rate, including the mouth as well, and the liver. Talking about lung GVHD, the overall response rate was 30%. 17% of these responses were CR, complete remission. So patient who start the palbociclib earlier, they achieved more than 86% overall response rate. Patient with severe chronic GVHD, the response rate was something around 74%. Patient with multiple organ involvement or 4 or more organ also showed 70% response rate. So indicating that the responses were equivalent across different subgroup of patients. This is important. The median time for response was around 4 weeks. And this is something really significant for this kind of heavily pretreated patient population. And around 2/3 of patients, the responses were seen between 4 to 8 weeks. So if there is a response, you will see it within the first 2 months of treatment with the palbociclib. Looking to the secondary endpoint, which is the median duration of response among responders, has been seen and increasingly over years, compared by 1 year and 2 years, and up to 80% of responses seen. They were continuous. And secondary endpoint looking into the Lee score, showing that responses were improving compared by 1 year versus 3 years. In terms of steroid taper, around 70% of patients, they were able to taper their steroid, and 20% of patients, they were able to discontinue their steroid. And in terms of calcium inhibitor, after 3 years, 47% of patients, they were able to reduce the CNI, and 20% were able to discontinue the treatment. And looking into failure-free survival, at 3 years, account for 42% of patient population. There were 58 increase in the quality of life in terms of metrics for quality of life. And the most common symptoms seen were fatigue. Fatigue is a known symptoms associated with palmocidal. However, other toxicities, including diarrhea, nausea, something can happen, but it's really something that we don't see it in practice. And even the discontinuation rate is not that significant. For example, overall, around 21% of patients, they actually discontinue their treatment due to disease progression, and 13% only discontinue treatment due to the adverse event. Cytopenia, we don't see it a lot with the palmocidal. Only 1.3% of patients, they develop grade 3 or higher thrombocytopenia, neutropenia, and 0% for thrombocytopenia. As I said, 13% only they discontinue treatment due to adverse event. For the failure-free survival in the intention to treat population, there were 75% at 6 months, and more than 50% of patients at 1 year. So I'd like to go quickly over at least 2 cases that from the earlier, showing our earlier experience with palmocidal. And we'll start with this case. This is a 19-year-old male diagnosed with severe aplastic anemia. He underwent match-related donor transplant from his sibling, and because there was a mismatch in the kind of weight, we could not do the bone marrow harvest. So we did the peripheral blood for aplastic. Otherwise, our actual approach is to do bone marrow harvest for those patients. So he underwent the transplant using flow-cy ATG with the cyclosporine and MMF GVHD prophylaxis. CD34 dose was 8.4. He engrafted nicely, neutrophil and platelet, and he developed some complication immediately post-transplant, which he passed through this complication. He developed acute GVHD. His main issue actually was a compliance. He wasn't really compliant in cyclosporine, because we don't see this usually with aplastic anemia patient. We have a high successful rate in the aplastic anemia with the minimum GVHD, but for him, he wasn't really compliant to the use of cyclosporine. So he developed acute GVHD of the liver, and then he was started on a steroid, and that led to the induction of remission without the need for a second agent. And then 7 months post-transplant, he started to develop moderate chronic GVHD, mainly in the mouth and the liver, started in a steroid, led to some improvement of his symptoms. However, 3 months later, he developed progressive chronic GVHD with scoring 2 NIH based on the NIH scoring in the fascia, 2 for mouth and 1 for liver. And so we increased the dose of steroid again. We add ruxolitinib, which is our standard at that time. Despite of this, after 3 months assessment, he still have severe GVHD with mild improvement in the fascia. So we offered him really ECP, but he did not really agree to do the extracorporeal photopheresis, although he lived in Riyadh, so logistically was okay for him. From our side, it was fine to do it, but he did not want to have a central line again. So he started on sirolimus in addition to the combination therapy, but again, he did not improve, and actually his fascia progressed a little bit. So we started palmocidal at that time. It was non-formulary, and we started palmocidal for him. And after 2 months, after starting the palmocidal, After 3 months, there was a significant improvement in his NIH score, mouth down to 1, and fascia from 3 to 1. Actually, the first response we see it within 4 to 5 weeks. He started to move his wrist joint, and his range of motion improved significantly. So he's now almost 3 years post-transplant, 2 years post-diagnosis of chronic GVHD. He has actually more than 18 months on pulmocidil now. Fascia 0, very, very, very minimum mouth finding, but he's completely asymptomatic. So I would say that he's almost achieved complete remission from his GVHD standing view. The second case is a case for one of my colleagues, which is really an interesting case. This is a 43-year-old female diagnosed with acute myeloid leukemia, translocation 821. She had also trisomy 4. She has also c-KIT mutation. She was treated with 7+3, and day 28 showed 8%. She was treated in another institution. It was 8%. Then subsequently she was started on AZA venetoclax. She received 2 cycles. Still she has bone marrow showing 10 to 15%. She was referred after that to our center for consideration of transplant. We induced her with FLAG-IDA. She developed some complication, and she did not really achieve good responses. Then we use high-dose RSE with gemcitabine azogomycin without significant response. Then we end up giving her MEC. She responded nicely to MEC, and she went into haploidentical transplant for her brother with the TBF reduced intensity conditioning regimen at that time from peripheral blood with BTCY, MMF, FK, GVHD prophylaxis. She had some complication, infectious and non-infectious complication post-transplant for someone who is heavily pretreated using haploidentical, and the use of TBF as well was associated with multiple complications. Within the follow-up day 60 bone marrow, she was in remission. There was 0.2% flow cytometry by flow cytometry showing clearly leukemia-associated positive blast. So she went into another 2 doses of donor lymphocyte infusion, which resulted in achievement of remission, but she developed, unfortunately, GVHD. At that time was grade 3 acute GVHD, skin, upper and lower gut, treated with the steroid, but she was refractory. She received ruxolitinib and ECB, which is our standard for any gut GVHD. We immediately moved from steroid into ruxolitinib combination with ECB, if possible, in terms of logistically and others. So
recording stopped.
Combination of treatment, and she achieved complete remission with the use of ruxolitinib and ECB. So 10 months post-transplant, she presented to the clinic with the new symptoms of progressive shortness of breath, and evaluation at that time showed that she has chronic GVHD of the lung. She scored 3 based on the NIH score. The FEV1 was very low. We started our standard protocol, which is FAM protocol, with 1 milligram per kg of prednisone, and after 1 month there was only mild response. Then we started her on ruxolitinib, which is our standard second line for this. For chronic GVHD. There was a plan to restart ECB, but she refused. At that time, she declined that. This is her picture. You can see here clearly the air trapping on the expiratory phase of the CT, and you can see the FEV1 is very low at 29%. Her mouth symptom resolved, but lung is stable with some SOBs, FEV1 very low. We thought that she will keep progressing, so we added pulmocidil at that time. And after 3 months of pulmocidil, she showed actually an improvement. This is something we don't see it usually at this stage of lung GVHD. She showed actually improvement, and there was an improvement even by like symptoms and by number. Her FEV1 went up from 29 to 37%. And steroid and ruxolitinib was tapered nicely, and now she's almost 1 year post pulmocidil initiation. She's off other immunosuppression except the FAM protocol, and she's maintaining on pulmocidil. 0 admission, since the initiation of pulmocidil, and now her lung function is plateauing without any significant symptoms. So this is what I would like to share with you, and happy to take any question. Thank you for listening.
Thank you, Dr. Badr, for this excellent presentation and keeping on time. So we have time for one question. So if there are any questions, please raise your hand.
So if there is no question, Dr. Badr.
Thank you, Dr. Badr, for your great presentation. Well, my question is about fibrosis, especially in late stage of chronic GVHD. Do you think it is reversible or mainly manageable?
Can you raise your hand? We don't know. Where are you?
Okay. Yeah, so usually for lung GVHD, usually it's not reversible based on the experience with other anti-GVHD treatments. So once fibrosis happens, usually unlikely to reverse the fibrosis. We don't have strong evidence that any agent can reverse the fibrosis of the lung. However, we've seen some data that there can be some improvement in the PFT by numbers of the chronic lung GVHD with the use of pulmocidil.
Thank you.
We can take one more question if there is any other question.
No more question, Dr. Badr. Thank you. So
thank you.
We'll move